So today on Gentle Dental, I'm thrilled to welcome Dr. Travis Barrett, a board-certified periodontist with a fascinating journey from serving in the U.S. Army to becoming a leader in periodontal care. Dr. Barrett was born in the Cascade Mountains of Oregon, served in Operation Iraqi Freedom, and later made Missouri his home, earning his dental degree from A.T. Still University, Missouri School of Dentistry and Oral Health. His training includes a residency in periodontics at St. Louis University, and he's been recognized with multiple honors for his dedication and skill. Today, he practices at Westport Periodontics and is passionate about helping patients achieve and maintain healthy gums. I'm so excited for you to learn more from him today. So, Dr. Barrett, can you introduce yourself and share your journey from going to the U.S. Army to becoming a periodontist?
Absolutely. Thank you for having me. It's a long story. So I enlisted in the U.S. Army when I was 17 years old. I was a junior in high school. Got stationed at Fort Sill, Oklahoma for my first tour. And I did permanent party there for about 3 years before I deployed to Iraq. During that time, I was a heavy wheel diesel mechanic and got out and went to undergraduate at University of Missouri in Columbia, where I was studying mechanical and aerospace engineering. Kind of got burnt out with that aspect of it. During that whole time, I was working as a diesel mechanic at nights and continued on. So I ended up working for Cummins International and for Detroit Diesel for almost 16 years before deciding to completely change career paths for dentistry, which is it's a big change. So I ended up getting my undergraduate degree in animal science once I had made the determination that engineering wasn't the path that I wanted to go through, and that was the fastest degree I could get in the amount of time that I had. Then I applied to dental school. I applied to A.T. Still University and got accepted. Spent the first 2 years in Kirksville, Missouri, and then finally transferred down to St. Louis for my last 2 years. Very fortunate that during that time I had applied to the periodontal residency program at St. Louis University, and they graciously offered me a spot.
Did you go straight from school?
I did go.
Okay.
I went straight from dental school into the residency program. That residency program is a 3-year program at St. Louis University. So
What made you want to do that?
I like the aspect of periodontics. Originally, I wanted to do oral surgery. I just like the surgical aspect of practice. But periodontics was more in line with what I wanted in a career, and that was combining not only the hand skills and the surgical approach, but the artistry of it. Periodontics is very plastic surgery like for the mouth, and that was more appealing to me than other aspects of dentistry.
For those that are unfamiliar with what a periodontist does, can you kind of tell us the difference between what you do between that and general dentistry?
Sure. So, a periodontist, our main focus is to preserve function and preserve teeth, treating mild to advanced cases of periodontitis. We also help patients maintain their function, replacing missing and unsalvageable teeth with dental implants, fixing gum discrepancies. So, if patients are starting to get recession or have a lot of inflammation in their gums, our primary mission is to help resolve that for them.
Can you tell me a little bit about like what a typical day as a periodontist?
Yeah, so our typical day starts in the morning seeing new patients, explaining what we do and what options we can provide to them to kind of help them with whatever periodontal ailments. It's usually followed up by surgical intervention. So these are the patients that have done deep cleanings, either with their general dentist or hygienist, and the results weren't what they were hoping they would be. They'll come and see us. We'll do a new patient exam. We'll kind of figure out what we could offer them to help get their disease under control. And then we follow that up with a surgical intervention of some form. We do that during the mornings. And then in the afternoons, we typically reserve those for new patient exams again and post-operative appointments, stuff like that.
When is it time for someone to see a periodontist?
The vast majority of our patients are referred to us from their general dentist. We have very few patients that come to us just looking for periodontal care. I like to refer to it as the general dentist is the quarterback and we're just the wide receiver. They would come and see us when the general dentist has done deep cleanings in the past and they take measurements around the gums and around the teeth, and those numbers aren't getting better. At that point in time, it's kind of beyond the scope of what general dentists or general dentist practice hygienists are comfortable treating, and that's usually when they come and see us for more advanced treatments.
And what kind of advanced treatments do you offer?
Many. So depending on what we're treating. So if we're treating gum recession, we have many different grafting abilities, free gingival grafts or connective tissue grafts to kind of help get the tissue back to where it's supposed to be or get the right type of tissue in the area. If it's missing teeth, we place dental implants. We do bone grafts to kind of help rebuild the jaw bones to where we can put implants in there. If it's periodontal disease, we do many, many surgeries, one of them being osseous surgery, where we kind of move the gums out of the way and reshape the bone and get the deeper numbers back down to a reasonable level that they can maintain at home. There's more advanced procedures like LANAP, which uses a laser to do surgery around the teeth and try to get the same accomplished goal, which is a little less invasive.
What kinds of problems or symptoms usually bring a patient to your office?
Primarily uncontrollable periodontal disease. So they've received treatment at their general dentist and it's just not resolving. Other symptoms or other problems, tooth sensitivity, recession. We have chronic bad breath, unplanned tooth movement, or your teeth are getting more mobile over time, or your gums just don't look right. They're really red, or there's spots on the gums that don't look like they look everywhere else. And these are usually indications of periodontal issues that would send people to our office as opposed to back to the general dentist.
Will you take biopsies if you needed?
We do. Yeah. So we'll biopsy tissue. Currently, we use St. Louis University pathology to run all of our pathological results, and we get those back in a pretty timely fashion.
For people that don't know what like recession is, or can you kind of explain
Yes.
that?
So the tooth has two main portions. The first portion is the root of the tooth, and then we have the crown or the enamel around the tooth that we typically see. The tissue attaches where those two layers of tooth come together. So in recession, whether that's through trauma or smoking habits or genetics or orthodontic movement or crowding of teeth, there's many reasons how we can get recession. But whatever reason caused it, the tissue no longer attaches at that level anymore. It starts sliding down the tooth. And whenever it slides down the tooth, we start seeing the root exposed. And that can cause a lot of sensitivity. It can also cause something called root caries or root cavities, which are the same process as when it attacks the enamel, but it does it at a much faster rate. And it's much harder to treat restoratively. That's what recession is.
And that's different than if a dentist is sending you to someone to do like crown lengthening.
Correct. So in crown lengthening, we are surgically causing recession around a tooth. We would do this if a tooth is broken off and your general dentist wants to do a crown on the tooth, but there's not enough tooth structure left for them to cement a new crown onto. We will actually take bone away from the tooth in order to cause recession so that the restoring doctor has tooth structure that they can use to hold on to that.
And is there kind of a formula to know if that tooth is possible to have crown lengthening, biologic width, or anything, case by case basis?
It's really a case by case basis. I think the most important factor is one, what tooth is it? If we're talking about any of your front teeth, we have to think about aesthetics. What's it going to look like with a crown on there? Is the tooth going to look really long or really tall? Do we have enough supporting bone around the tooth? If we take any more bone away, is the tooth going to get loose? For the back teeth, they're multi-rooted teeth, so they have more than one root. And where those roots kind of split off, you have something called a furcation, and that furcation should always be in bone. That's our hope. So if I remove more bone, am I going to expose that furcation? Because that's going to decrease the prognosis long term for that tooth, and I don't want to do that. And the other big portion of that is the tooth really restorable? If I see a patient that will come in asking for crown lengthening, my first instinct is to look at the radiographs, look clinically, and make sure that putting a crown on this tooth is really a good idea because it's not always a feasible option.
This is a side note, but does insurance typically cover procedures that you guys do, or is it usually fee for service?
So at our practice, we submit all claims to insurance, and insurance will pay a portion of most procedures. Your scaling and root plannings, some of your surgical procedures are typically covered pretty well by most insurances. You are going to have some out of pocket expense associated with it. Yeah. It's really insurance specific on
Yeah.
what they're willing and not willing to cover.
What is the youngest patient you've seen and the oldest patient you've
The youngest patient I have seen was an 8-year-old for a frenectomy. She was getting ready to go into ortho. And a frenectomy is the elastic tissue underneath your upper lip that attaches to the gum tissue. Sometimes when your teeth erupt or come into the mouth, the front teeth are really far apart. And when the orthodontist puts braces on and squeezes that together, that elastic tissue can get caught. When it gets caught, when the braces come off, it'll actually force those teeth back apart again. And so we'll go in there and we'll remove that elastic tissue so that teeth will stay where they're supposed to be. My oldest patient was a 98-year-old veteran who has been coming to the practice for probably 20 years to maintain his periodontal disease. So we see the whole range. Most of our, if I had to average out our patient, we are more older patients than younger patients. Most of our younger patients are somehow related to orthodontics. Most of our older patients are more of maintaining the periodontal treatments so they can keep their teeth. And then our middle patients are kind of everything. We go from simple procedures to very complex dental implant placements, bone grafts, tissue grafts, and things of those nature.
So we're going to talk a little bit about perio disease. If you're watching this and you don't know exactly what we're talking about, I would recommend you go back and watch the interview with the dental hygienist Allison, who goes into great depth about this. But in the meantime, can you talk a little bit about what gum disease is and what are some early signs patients can keep an eye out for?
Sure. Yeah. So Allison did a fantastic job kind of explaining the details of this. Gum disease comes in really two forms. The first form is gingivitis, which is just localized inflammation in the gums, typically plaque induced. So it's caused by bacteria around the gum layer. And the second one is periodontitis. Periodontitis is the more advanced gum disease. The main difference between the two is that gingivitis is reversible. So if you get the bacteria out and you're keeping it clean at home, the inflammation is going to go away. With periodontal disease, it isn't going to go away. Once you have it forever. We can treat it, but we cannot cure it. And it's progressive. So over the span of years, the disease will progressively cause more and more and more bone loss and structure loss.
And if they don't do anything about it, then they're at risk for losing teeth.
The risk for losing teeth is very high, among other things. Longitudinal studies have found evidence that it can be linked to cardiovascular disease, to stroke, to Alzheimer's, to inability to control their diabetes and their glucose. It seems like every 1 or 2 years, another study comes out where another disease is being tied to the oral pathologies that we find with periodontal disease. So it's not just inflammation and bleeding. The mouth is the gateway to the rest of your body. When we have things in the mouth that aren't right and aren't well, that transfers to other areas.
Can you talk a little bit about like pregnancy and how that can affect gum sometimes?
There's research articles that have been conducted that untreated advanced periodontal disease causes low-term birth weights in babies. It can also cause something called pregnancy tumors, which is a pyogenic granuloma, where you'll get these nodules on your gums during pregnancy, or really any hormonal changes. It's not only in females, it's more prevalent in females, but it can happen in males too. In females, we see it typically during pregnancy and at menopause, where the hormones are just going crazy. And these little pregnancy tumors are benign, but they can be scary. They can be really scary. They bleed very easily. Typically, we just take those off, and there is a prevalence for them to come back over time. But really, the biggest downside to having advanced periodontitis when you're pregnant is the low-term birth rate.
And then do some people with the hormonal changes have like pregnancy gingivitis?
They do. So pregnancy gingivitis is very common because of the hormones, not necessarily to the point where we have to do surgery or any significant treatment at that time, more so improving home care. What you're doing at home plays a huge difference regardless of the problem that we have, whether that's gingival recession or gingivitis, periodontitis. Home care is by far the most important factor.
Is there anything gum related that's to do with the brain?
If Alzheimer's. I think that's the only thing that research has proven.
What are some of the most common misconceptions about gum disease?
I think the biggest misconception is that all gum disease is treatable and curable, and it's not. So it's all treatable, but not curable. We can't cure periodontal disease. Our whole mission after a patient presents with periodontal disease is to treat it, to get it under control, and to decrease the progression rate. Since it's a progressive disease, it's going to get worse over time if left untreated. So our mission is to get it under control, keep it under control for the remainder of your life so that we can maintain your function and ability to maintain your natural teeth as long as humanly possible. Once we lose our natural teeth, there is not a good replacement. Implants are helpful, but it's not a one-for-one exchange. We can save a natural tooth far longer than we can save a failing implant. By far.
How important is home care in preventing and managing gum disease?
Absolutely crucial. So I like to tell my patients that we're only 10% of the equation. We can do all the surgeries, we can do all this stuff to kind of get the baseline, get your strong foundation. But if you go home and your home care isn't adequate, all that work will go away just instantly. You can come every 3 months and do periodontal maintenance where the hygienist will clean your teeth and keep the bacteria away. But if you go home and you don't brush, your numbers are going to get deeper. your progression rate is going to stay high. 90% of it is what you do at home and the habits that you form following treatment. That's going to be the deciding factor on how long you get to keep your teeth.
Daily habits do you recommend for someone trying to protect their gums?
So the same adage we've heard forever, twice a day and floss. Flossing is incredibly important, not just for cavity prevention, but because we're getting the bacteria out from underneath the gums between those teeth. Water flossing is a controversial thing in the periodontal world because it doesn't floss. So people call them water flossers, but they don't actually floss your teeth. There's no mechanical debridement actually pulling bacteria off the teeth. So what it does is in patients who have bridges or really big contacts where their teeth don't come all the way together, it does a really good job of getting all the loose stuff out, but it's not a flosser. Using actual dental floss and running it along with those teeth and the roots underneath the gums, you're keeping out the bacteria that's responsible for the disease that you're trying to treat. And really just brushing twice a day, the full 2 minutes, making sure you're hitting all the surfaces of your teeth, things that most people know. It's surprising when people don't do it or don't do it correctly or were never taught correctly. I don't think I was taught how to clean my teeth appropriately until I got into dental school. So there's this huge education gap where the patients aren't being taught what they actually need to know to keep their teeth. And that's where hygienists are invaluable. Yes, they clean teeth. Yes, they do a great job. Yes, they're on top of it and they're watching out for you. But take their education to heart because they're teaching you. They're telling you what you got to do to keep your teeth a long time. So
So when someone is brushing, are they supposed to touch the toothbrush to their gum?
slightly. We don't want people just scrubbing. We don't want them scrubbing the gums. We don't want them scrubbing the teeth. I'm a huge advocate of electronic toothbrushes, especially toothbrushes that tell you if you're brushing too hard and that have timers on them that tell you when to move. Oral-B has a really good IO product, and I like it more than others because of the anatomy of the head. It's a smaller, rounder head. They come in soft bristles, so soft bristles are always preferred. People think that you got to get in there with a scrub pad to get the stuff off, and you really don't. It's not necessarily how hard you're brushing, it's the frequency. How often are you brushing? And if we can do that with a softer bristle toothbrush, preferably an electronic toothbrush, it tells you if you're brushing too hard. It's far more efficient and effective at removing the bacterial plaques than hand brushing is.
How would you describe like what an SRP scaling root planning is, and then how is that different from a regular cleaning?
SRP is scaling and replaning, or your general dentist or hygienist may call it a deep cleaning. Whenever you go in for your normal cleaning, most of the time, unless you have a lot of sensitivity, they don't numb you up. They just go in there, they polish your teeth, they take out the bacteria that you're missing between your teeth, and we'll see you in 6 months. Scaling and root planing is different. So we usually break those appointments up into two. So you'll do half of your mouth in one appointment and you'll come back and do the other half. And these are for patients where when the hygienist or the dentist was taking measurements, those numbers were 4 or greater. 3 to 0 is considered healthy, 4 and above is considered diseased. So what they're doing is that they know there's bacteria under there and they have to go after it. And that usually takes a lot of work. Some of the bacteria has been down there for a long time. It's become what we call tenacious or very difficult to get off. They got to work at it. It's hard. And so to do that, they got to make sure you're comfortable. So they're going to get you numb and it takes a long time. As a rule of thumb, if you're doing a deep cleaning, usually it's about twice as long as on per half as it would be to do a full mouth normal cleaning because they have to dedicate so much time to getting that bacteria out of there for you. So that's the main difference is you're going to be numb. They're going to be scrubbing a lot harder and a lot deeper than you probably have ever had before. And then after that, the regimen changes. So instead of getting your teeth cleaned every 6 months, you're going to get it cleaned every 3 months. Research shows that, biofilm or the foundation that bacteria uses to attach to the tooth develops within 12 hours after brushing. That's where the brushing twice a day comes from, is every 12 hours, we want you to get the biofilm off of your teeth so the bacteria can adhere to it. But if we miss the biofilm and some develops and bacteria starts to develop, it takes about 90 days for that bacteria to become what we call pathologic, or it to start causing more damage or the progression of your disease to increase. So that's where the 3 months comes from. Every 90 days, we want to see you and we want to get off all that bacteria before it has a chance to amplify the problem. And then you'll do that pretty much for the rest of your life. That's where it changes from an adult prophylaxis, which prophylaxis means prevention. So we're preventing a problem versus periodontal maintenance, where we did initial treatment, we did the deep cleanings, and they were successful, hopefully. And now we're trying to maintain that. And in order to maintain that, we got to make sure that if we still have any residual pockets that are deeper than 3, so if we have some 4s and 5s that are left after the SRPs, that we're every time we're getting down in there and we're getting that bacteria out so they have a chance to heal or at least stay stable. A lot of periodontal disease isn't necessarily taking a 5, 6, 7, 8, 9, 10 millimeter pocket and making it a 3. What we're looking to do is we're looking for improvement and then we're looking for stability. If I take a 7 millimeter pocket and I make it a 5, can I maintain that 5 over the long term? So once the SRPs are done, we'll do yearly reevaluations where we go in there, we take measurements every year and we're looking and say, hey, this was a 7 before treatment. It's a 5 now. It was a 5 last year. It was a 5 a year before that. So yes, 5 is still considered disease, but we're maintaining a 5, which means that I'm okay with that. I'm okay with maintaining a 5 as long as it's maintained. The minute that 5 goes back to a 6 or to a 7, now we have to come back and readdress it.
If someone isn't maintaining going to those every 3-month or 4-month visits, is it possible that they may have to get retreated for that deep cleaning again?
Absolutely. For example, if you have a patient, and this happens all the time, right? Because the disease is progressive. So you can have the patient who is compliant, who gets the deep cleanings, they get checked out, everything looks good, they've been consistent with their 3-month maintenance. That 7 that turned to a 5 is still a 5, and then 2 or 3 years down the road, now it's a 6 or going to a 7. Not necessarily because anything that the hygienist did wrong, for sure, or the patient did wrong. Just it's progressive disease. So there are certainly circumstances where, hey, we're getting some deeper probing depths over here. Maybe we ought to retreat this, do another deep cleaning, get you numb, really get down in there and get that cleaned out and see if it responds well to that. And then if it doesn't, that's where the periodontist comes in, and we have surgical interventions that we can offer to help improve that and kind of get you back down to your foundation. But there's also patients who get the deep cleaning and don't have good results. Just because the deep cleaning is our non-surgical therapy doesn't mean that all patients are going to respond well to it. So a secondary treatment would almost always be necessary, whether or not that's scaling and root planing. And that's a patient by patient thing. More than likely, it wouldn't be. Most insurances won't cover it, but once every 2 or 3 years. So that would be more of we're going to have to do some form of surgery to kind of get this under control for you. Or you have the patients who are kind of hit and miss with their maintenance appointment. They'll go to their SRPs. The initial results are very good, and then they don't come every 3 months. They come every 6 months, or you'll see them next year. And of course, all the results and the positive results that you got back from the initial treatment are no longer there. That's when another scaling and root planing would be beneficial because you know you had success the first time. There's a high likelihood that if the patient becomes compliant, that doing it a second time, we can get that back down to where it's supposed to be without surgical intervention.
You're talking now about surgical intervention. So what would you do differently at your office than you would at a general dentist?
Yeah, so we wouldn't really do anything different. If you've never had periodontal treatment done before in the past and you go into your general dentist, your gums are bleeding everywhere, they're swollen, they're red. There's a lot of general dentists and there's a lot of hygienists that it's like, this is too much for me to try to manage here. And they'll send them to us. And our process is going to be the same as it would be for the general dentist. First thing we got to do is we got to get the bacteria out. So we're going to do the SRPs at our office. We're going to get you cleaned up. And then we're going to do a reevaluation to see where everything's at. If all goes well, those numbers are going to be good. And then you will continue with a 3-month periodontal maintenance program where every 3 months you're coming to the office for a cleaning. In our practice, we typically alternate with our general dentists. So we'll do the deep cleanings. I'll see him a month later. I'll check on him, make sure all the numbers have gotten better. And then we'll see him for the first maintenance 3 months later so that we can emphasize home care. And we have tips and tricks to kind of help them access difficult to reach areas. And then 3 months after that, they're going to their general dentist. What we don't want is a patient to only come to us because when we take our x-rays and we're doing our exams, I'm not looking for cavities. We're looking at the bone, we're looking at the gums, we're looking at the overall periodontal condition, we're looking for any pathologies. Our mission isn't to take radiographs and find decay and see if the crown is fitting appropriately. That's the general dentist. And we want to make sure that you have the opportunity to see that patient at least every 6 months to make sure that restoratively everything is okay. And so it's kind of one of those, it's a cooperation really. I know that the patient is being treated restoratively. And then you know that periodontally, we have them under control. And if anything pops up, that we have control over that. It just not necessarily separates the responsibility, but it's just ensuring that patient has the best possible care. Between our office and your office, we're making sure that we're doing everything we can to maintain these teeth forever. Yeah, so we don't really do anything different. It always starts, we call it phase one treatment. So when you have scaling and replaning, it's non-surgical phase one treatment. It's always ground zero. That's where we build our foundation from. And from there, that's where we grow. Either you respond very well to the treatment and we're able to maintain you every 3 months, or you don't respond very well. And then we jump into phase two, which is our surgical phase, where we say, okay, we did the deep cleanings. Your home care has improved greatly, but your numbers aren't improving like they should be. We have to be a little bit more aggressive to get this under control. If we don't, then it's going to continue to progress to the point where we're losing teeth, and we don't want to go there. So that phase one, whether it's done at our office or whether it's done at the general dentist office, SRP is SRP. Our hygienist at our office had the same training as the hygienist at your office. I think really the only main difference between the two is our hygienist see advanced perio every day. That's all they do. We don't have the prophylaxis cleanings where we're just going in and polishing and getting a little bit of bacteria off and seeing them in 6 months. We don't see those patients in our office. Usually the patients we see are the patients that went to the general dentist and they're like, you have to go see a periodontist. This is beyond our control. So they're hard. Our ladies are very, very good at getting down into really deep pockets and doing very, very, very hard cases every day. Yeah, they're rock stars. Yeah. Our girls are awesome.
Shout out to them. For anyone that would need potentially like a treatment like a laser, what does that actually do?
Yeah. So LANAP, or laser assisted new attachment protocol, it's termed, it is a surgical intervention, but it's less invasive than the traditional osseous surgery. So we have lots of different surgical options in perio. The two, as far as treating uncontrolled periodontal disease, are either osseous surgery or osseous surgery with the laser. Main difference: not everybody's a good candidate for the laser. Not everybody's a great candidate for traditional osseous surgery. If you have a lot of bone loss, like you barely have bone holding your teeth in, traditional osseous surgery is probably not the best option for you, because it's going to require that I take more bone away. And if I do that, then I'm just decreasing the lifespan of your teeth even more. That's where the laser comes in super beneficial. So the laser, we don't adjust bone. We don't even see bone. We trace the tooth root with a laser. And what we do is we go all the way down to the bone level. And it's a fiber optic cable that the laser runs through. And everything within a 5-6 millimeter circumference of the end of that diode is killed. So we're losing the inside layer of tissue that surrounds the tooth that's affected. We're cleaning the root, any bacteria that's in the sulcus or the area between the gums and the tooth attachment. It all dies. And then we go in there just like a deep cleaning and we scrub your teeth all the way to the bone level. And we're getting all the bacteria out. We're getting all the stuff off of your teeth, with the exception that we can't see it, right? It's still just like the deep cleanings, it's still by feel. We can kind of pull the tissue away from the tooth a little bit just due to that inside layer of tissue the laser removed, but it's not really enough to see all the way down. And then we go through the laser again. Same protocol as the deep cleanings. We do half your mouth at a time. And then the second time we go through the laser, any bacteria that wasn't flushed out during the deep cleaning portion of the process is killed a second time with the laser, and it creates a blood clot around those teeth. And with your deep cleanings, the mission is to get the bacteria out and allow that tissue to reattach to a clean root. With the laser, we got rid of that tissue. That tissue was affected. Maybe you've had SRP several times and it didn't work. The likelihood of going in a third time for a deep cleaning, having that tissue reattach, is pretty low. So we remove the tissue. And now we're trying to get brand new tissue development that's not programmed, right? We want it to attach to that root surface. It doesn't know any better. Right. So that's the benefit of the laser. With a traditional osseous surgery, what we're doing is we're making an incision around all your teeth and we're moving your gums completely out of the way. Now we can see the bacteria. We can see the plaque down by the bone that's been causing all your bone loss, and we can get rid of it. If we have enough bone, traditional osseous surgery by far is the gold standard, hands down, because now we're able to see defects in the bone. Maybe some of your defects are graftable and we can put some bone graft in there and get that bone back. If it's not, then we reshape your bone so your tissue sits flat. Traditional osseous surgery is probably the only surgical intervention we can do orally that we can take a 10 millimeter probing depth and force it to be a 3. It's the only one that we can predictably do that with. And we do that because we are manually forcing it. We're reshaping your bone, we're cutting your tissue down, and we're pushing it down where it needs to be. The downside of that is it causes a lot of recession. We're forcing you to have recession because we got to get the tissue down to where the bone level's at. We can't build the bone up, so we have to bring the tissue down. The laser, we're not cutting anything off besides the inside area around the tooth. That's all we're removing. So we're not really forcing the tissue down. We're just trying to get new tissue to develop that will attach to the tooth. Studies have shown that Lannat procedure can improve bone, can get some gain in bone. Clinically, I haven't seen it. It's not something that I advocate or advertise. I'm sure there are situations where we can get some increase in bone levels around teeth. But I think by far and large, at least for the patients that we tend to use the Lannat protocol for, gaining a bunch of bone isn't going to do us a lot of good. Right now, we're just trying to maintain teeth and keep teeth in there. And if we get the soft tissue to attach, that's going to prevent bacteria from having access to the bone, and it's going to really decrease the rate of progression on that disease.
So, what factors do you consider for prognosis of a tooth with like a deep pocket or recession? Like whether that's like occlusion or anything?
Yeah, so occlusion plays a critical role, right? How your teeth come together on the top and the bottom. We have this thing called secondary occlusal trauma. So if the top and the bottom teeth in certain locations are hitting each other too hard, it can actually cause damage to the ligament that surrounds that root. I think the first thing to recognize is that the tooth, it's surrounded by bone, but it is not connected to bone. There's a ligament in there. It's a shock absorber for your teeth. And when you eat a jawbreaker and you bite down on it and your teeth hurt, that's that periodontal ligament that's telling you, hey, stop that. Don't do that anymore. So with secondary occlusal trauma, when the teeth come together and they're putting those forces, your body reacts. It reacts to everything. So if they're hitting too hard, your teeth might start getting loose. And you're like, oh, doc, this tooth wasn't loose a year ago. Now it's loose. And that's because your body is actually making that ligament wider. It's making the shock absorber bigger and help withstand those forces. But whenever that periodontal ligament expands, the tooth mobility and everything else, you're starting to reduce bone around there. Your probing depths can increase. Almost always it's caused by bacteria, but there are some circumstances. Ortho being a huge part of that, right? So if you have a bunch of crooked teeth and your teeth don't have space between them and your roots are kind of stacked on top of each other, there's nowhere for the bone to go. And there's nowhere for the tissue to attach. So the gums themselves will not attach to the white part or the enamel of your teeth. They just don't. They have to, like we talked about earlier, where the enamel and the root come together, that junction is where the tissue attaches. So if that's crammed up against another tooth, or if one tooth is kind of sitting behind another one, the tissue doesn't have the ability to attach to that area. It just won't attach. And so you'll get really deep probing depths there, even though the patient may not have periodontal disease. They're super susceptible to it now because now they have a cave or a cavern for that bacteria to go and hide. Ortho's probably the biggest one.
Gum grafts are a big topic. And so,
Yeah.
can you kind of talk about what that is and when you know you need to not have it?
Yeah, so gum grafts are very beneficial for many people. There's really two reasons why you would get a gum graft. The first one is we have two types of tissue, just very plainly. We have what people think of as gums, which is something called keratinized tissue that's around our teeth. It's protective, it's functional. It's what actually is surrounding the tooth, and when we're eating and we're chewing, it's preventing damage. So it has a functional reason. The rest of the mouth is covered with something called mucosa. Mucosa is the stretchy elastic tissue, makes up the inside of our lips and our cheeks. It's not meant to be protective. It's functional, but in a different way. It's meant so we can stretch, so that we can have a bolus of food on our right side and be able to move it side to side. It's not there to protect the teeth, right? One type of graft that we do is a free gingival graft. And that is because that the protective tissue around some of our teeth, usually it's in the front bottom, goes away over time, whether that's through trauma, recession, orthodontics, smoking habits, all kinds of different things can cause recession. But if we lose that tissue, then the mucosa will come in and fill in that spot, and it's non-protective. So what does that mean? Well, that means that your recession is going to rapidly increase over time because the tissue that's actually attached is no longer present. So the free gingival graft, we harvest from the roof of your mouth, and we're taking that top layer and we're transplanting it down where it's missing, and we're allowing that tissue to come back. That is when we don't have the correct tissue type in that area that we need to actually protect the teeth. You can get root coverage with it, but that's not its main intention. Its main intention is to get the correct type of tissue that you need for long-term stability of the gingival complex. The second type of grafting we do is connective tissue grafting. Connective tissue graft is when you have the appropriate type of tissue in the area, but you have recession, whether that's through the multitude of reasons to get recession. What we do there is we take the inside layer of the roof of the mouth. So we take that top layer, we kind of move it out of our way. We take the underlying tissue that's connected to the bone and we take it out. And then we transplant it just like we would with a free gingival graft. The main difference is with the connective tissue graft, we're not trying to change the overlying tissue type. We're trying to thicken the tissue. We're trying to get it to cover your roots. We're trying to get rid of any sensitivity that you have. The tissue that you have down there now is the same tissue you're going to have. We're going to make an incision along your teeth. We're going to move it out of the way. Connective tissue goes underneath, and then your current tissue is going to completely cover it. We're not changing the type. We're changing the architecture. We're giving you some thickness. It's going to add protection to that tooth. It's going to reduce your sensitivity. It's going to cover your roots.
Do you work alongside the dentist or orthodontist if it is like a occlusion issue?
Absolutely. Absolutely. So a lot of times when the patient comes from the general dentist, the orthodontic conversation's already been had. Most general dentists understand the relationship or the correlation between just bad tooth position and other oral problems. So that conversation's already been had, whether they've done Invisalign or whether they've given them a referral to an orthodontist. If not, then a lot of times I will refer to an orthodontist just for an evaluation to say, hey, is something even feasibly doable to make this a better situation for the patient? Sometimes it is, sometimes it isn't.
Is the gum grafting painful and is there like a big recovery process?
It can be painful. Now, if you get on Google, it's going to tell you it's the worst thing in the world. It's absolutely horrible. Although it's not pleasant, it's very doable. So, in all the years of doing this, I've never had to prescribe a narcotic pain medication. Ibuprofen and Tylenol have always been enough to take care of any residual pain. Wherever the graft goes, typically has the swelling and the bleeding, and wherever the graft comes from, typically is where the sensation of pain comes from. So, for instance, on a free gingival graft where we harvest that top layer of tissue, it feels like a really bad pizza burn. And how long does that last? Well, it's very patient specific, but usually between 2 and 3 days. For the connective tissue graft, it actually feels a little better because we're not taking that top layer of tissue away. We're putting it right back where we found it. So it still feels like a pizza burn, but just to a lesser extent. We do things at Westport Periodontics that help with that. The first thing we do is we have a thermoplastic molding that we mix. We make a surgical stent at the time of surgery that the patient wears for 2 days. So the first 2 days, the donor site is not being affected with liquids being on it. It's not getting traumatized by food when we're chewing. It's just kind of self-contained. And then after the 48 hours when the patient takes it out, they have the choice on whether they want to wear it or not during eating. It helps a lot because just like a sunburn, really, or any kind of carpet burn or anything that you've had in the past, the only time it really hurts is when something's touching it. So even with a free gingival graft, if we didn't do a stent, it wouldn't hurt all the time. You're going to be able to sleep at night. You're going to be able to go to work. You're going to be able to do all your daily things. The main difference is when you eat, it's not going to feel great. Or when you drink primarily acidic things or carbonated beverages, it's not going to feel great. That's where the stents really help a lot to kind of help cut down and ease that pain. And then everybody's pain tolerance is a little different. Some people don't manage it as well as others. Some people expect it to be horrible. And when we see them a week later, they say this wasn't a big deal at all. So really is very patient specific. But we do everything we can to make sure you're as comfortable as possible. And the healing is very fast. So within 6 weeks from the date of surgery, I could reharvest another free gingival graft from the same exact spot as if nothing had ever happened. Between 1 and 2 weeks is typically when we take the stitches out from the bottom and the top or wherever the graft is at. And if there's any on the roof of your mouth, we take them out at that time as well. And usually at that time, the surgical site is healed. It's immature, but it's healed. And most of the pain, if not all of the pain sensations are gone. And you're pretty comfortable at that point in time. And then it's just a waiting game to kind of see what your body's going to do with it.
What happens if gum recession is left untreated?
You're going to have a higher prevalence of root cavities. Like we talked earlier, usually root cavities, once they start, they develop very fast. It's very hard to treat. The material that makes up the root surface of a tooth is not enamel. And most of the dental materials we have available to us today were specifically designed to fix cavities in enamel. So the restorations don't hold as well. It's harder to seal the dentin than it is to seal the enamel surface. So that's certainly a concern. But the biggest concern is sensitivity. Once the sensitivity develops, it typically doesn't get better on its own. There's Sensodyne toothpaste, which can certainly help. But if we're able to fix it, that's usually the better option. Now, a common question that I get is if I don't treat the gum recession, will I lose my teeth? And the simple answer to that is no. Nobody that I have ever seen has lost a tooth due to gingival recession. They've lost the teeth either for restorative reasons or because of the underlying problem that caused the recession to begin with, whether that was untreated periodontal disease, large bone defects. So your gum tissue always follows the bone. If you have a lot of bone defects around a tooth, the tissue is going to follow it. Unless we can identify and address the primary reason why you had the recession to begin with, then you certainly end up losing that tooth. But it's not because of the recession itself. It's because of the other factors that are in play.
If you're doing a gum graft, especially like on the lower anterior, would you recommend a frenectomy if
It's done at the same time. I don't even charge separate for it. It's part of the free gingival graft. On the top, we very rarely ever need it. Top it's literally only for ortho. But the bottom, sometimes we can get a bottom. Like if we're doing a connective tissue graft, I'll do a separate frenectomy first, just so it's not pulling on it. But usually by the time the frenum really creates a problem, it's already in free gingival graft area. And when we do that, we just make an incision across and all of that goes down. So
you have to do, then you mentioned a tongue tie, so you do those as well.
But yeah, we do tongue ties for adolescents through adult. Usually this is in combination with myofunctional therapy where they're learning how to use their tongue. We do some younger kids, infants to toddler are usually done by the pediatrician's office. But as they get older and their faces mature more and they develop a tongue tie or speech pathology due to a tongue tie, we do remove those for them. Like I said, in combination with myofunctional therapy and learning how to use their tongue appropriately.
And does that help too with potentially like sleep apnea? And
It can because when you're tongue tied, you have a limited range of motion with your tongue. A lot of patients have it so severe where they can't even put their tongue to the roof of their mouth, at least the tip. They can put the base of the tongue to the mouth, which is where the sleep apnea can play a part. Is they've gotten so used and so accustomed to using the base of their tongue that when they're sleeping, it's just uncontrollable, right? So it's closing off that airway. Once you release the tongue and you go through your myofunctional therapy, and it sounds silly, but a lot of these patients, especially the adolescents, teens, adults, young adults, it's amazing how hard it is to train them how to appropriately use their tongue. Some of these patients will be in myofunctional therapy for years, just learning how to use and function with their tongue like they're supposed to. And oftentimes we want them to start myofunctional therapy prior to the tongue tie surgery so that they have an understanding of what's going on beforehand. And we give them a set of exercises to do once the tongue tie is done so that the muscle can stretch. It's never been stretched like that before. We want to start training it right away, what we want it to do for us. So yeah, it certainly helps.
all right, so let us talk about dental implants. Are dental implants, and how do you compare them to like bridges or dentures or replacement options?
We have multiple options. We have a single tooth replacement implant, which is you had a tooth, they had a crown and a root canal on there. The root canal went bad. The root canal specialist or your general dentist can't retreat it, and so it has to come out. That's where a single tooth implant would be beneficial for you. So the tooth be taken out. Ideally, bone grafting would be added at the same time of extraction so we can preserve all the bone that we can for that dental implant. We let that heal for 3 to 4 months, and then we can go in and place an implant. The big benefit of an implant over a bridge is that we don't harm any of the adjacent teeth. The implant is a standalone tooth, just like the natural tooth that was there before. And with a bridge where we have to cut away tooth anatomy in order to seat the bridge, the implant is it's self-contained. It's a titanium screw. We make a series of holes where we want the implant to be placed, and we screw it in just like a deck screw. And we let that heal for another 3 or 4 months. And then your general dentist will place a crown on it to make it look like a tooth again. Several advantages to that. One of the advantages is if, heaven forbid, anything were to happen to that implant and the implant were to fail, we just take it out. And the other 2 teeth next to it are still completely fine. There is an option to go back in and try to place another one in the future, or that bridge is still plan B. So if we go straight to a bridge option or a restorative option, and that bridge were to fail, say you had a tooth that fractured or had a root canal on it and it failed, then it couldn't be saved. Now you've lost everything. The bridge no longer is going to work. You lost one or both teeth, hopefully not both. And so now you have a much bigger problem. And I can't promise you that implants are going to be an option. So that's where the implants as a single tooth restorative option are beneficial, probably more ideal than any other treatment. Because even if the implant were to not be successful, we still have restorative options to fill that space for you, where the same may not be said the other way around. For dentures, so you have no teeth left and you have traditional dentures. Several things that come along with that. One, dentures typically don't fit that great forever. They may fit great in the beginning, and then as we age, our jaws are going to change. Our bodies are use it or lose it. So if we don't have root systems in the bone supporting the bone isn't going to stay there. As we get older, we're going to get something called atrophy. So the bone is going to slowly over time diminish. And you could have dentures on day one and they fit amazing. They look great. You love them. It's amazing. And then in 5 years, they're going to be falling out of your mouth and you're putting half a tube of glue to keep them in place. And then you're upset because we have to go in and make you a new denture because that one doesn't fit anymore. And it's going to be a progressive problem until you get to the point where you can't have a denture anymore. And then we're in big trouble. And I hate it. I hate to see it because at that point in time, there's very little, if anything, we can do to get teeth and function. The quality of life is diminished at that point in time. So the earlier that we can assess the area, the better. So if you have to have all your teeth taken out and you're going to be in dentures for 6 months to a year, that's great. Fantastic. Get used to it. See if it's something you can tolerate or not. And then there are implant supported dentures that can help with that. So for instance, if you had your dentures and you hated it, you can't taste your food, hot and cold isn't the same anymore. You can't keep them in your mouth. They just keep falling out, more so with the bottom than the top. Then we have implant supported. Implant supported is we put some implants, at least 2 on the bottom, at least 4 on the top, and they have something called snap abutments. So it's just these little pins that come out of the gums, and the denture will actually snap to it. Several benefits of that. One, the denture is far more stable. Two, we can get rid of the palate. Whenever we cut the palate off the denture, all your taste comes back and your temperature sensitivity comes back, and patients just generally get along with it much, much better. For the bottom, just the anatomy of the bottom jaw and the tongue make bottom dentures very, very difficult. Even if they fit good on day one, probably by 2 or 3 years in, they're not fitting anymore. Patients get frustrated. They don't stay. When the extractions are done, if we can get 2 implants in there, it's the same thing. Now we have something that can stabilize that denture long term. And those implants being in the bone, they're supporting the bone. So we're not going to lose as much bone in those areas as we would in the surrounding areas without it. The third option is just what we call a fixed implant bridge, where you don't want something that pops in and out anymore. You want something that is screwed on, you wear it all the time, and you live your life and don't have to worry about it. That is best treatment planned in advance, if possible. We can do it in stages. If you had to have all your upper teeth taken out, maybe there are some teeth we can keep in there for a while, and we can use those to support a temporary or something along those lines while the implants heal, because it's a long process. I am not a believer in immediately loading implants. What that means is when you put implants into the jawbone, they're tight, but they're not that tight, all right? And during the healing phases, you actually lose bone before you gain bone. So as you go through the different phases of healing, you're going to lose a little bit of bone. That implant's actually going to get looser than it was the day you placed it. We don't want to move that implant during that time. Your body is very particular on how it heals. And if anything disrupts it, there's a chance it just won't heal. When we immediately load the implant, what we're doing is we're stressing the implant from day one through phase 1 healing and phase 2 healing through final healing. There's loads on these implants. Even if you have 10 implants on the top, yes, the forces per implant are less, but it's still loaded. It still has force on it. The more ideal way to do it is to use some form of temporary. So have a traditional denture temporarily, have the implants placed, have them covered up in gum tissue so they can't be disturbed, and just wear the denture for a few months, 6 months, 7 months, whatever it takes for those implants to fully integrate. And then once they're integrated, now we can open them up and we can put different tops on there and we can load the implants safely. Does that mean that if I do it that way, they're always going to be successful? No, nothing is absolute, right? So nothing is guaranteed. Nothing has a 100% your entire lifespan warranty on it. Implants that are even placed correctly and allowed to heal correctly can still fail. for a multitude of reasons. Smoking's a huge cause of implant failure. It's a vasoconstrictor, so it squeezes your blood vessels together. And without blood vessels and without blood, you don't have healing. That can be a huge problem. Diabetes, uncontrolled diabetes, where your blood glucose is above 6. Your healing is hindered. Sometimes it's just genetics. Sometimes your body just doesn't want titanium. We see it with artificial knees. We see it with artificial hips. We see it with dental implants. Sometimes your body just rejects titanium, whatever reason. There's a long list of things that can cause implant failure, some that we probably don't even know of yet. There's other times where, okay, well, maybe not all of your teeth need to come out. Maybe you have 3 teeth on your right side and 4 teeth on your bottom, but you still have several teeth down there that are in really good shape, very well periodontally supported, and you don't want to lose them. And I agree. You shouldn't lose them. So we can strategically place implants, maybe 1 on this side and 2 on this side, that you can have a partial denture that's both, well, really 3 things. It's tooth supported. So whatever natural teeth you have, it can hold on to those. Tissue supported. So it's going to partially rest on your gum tissue. And then it can be implant supported. So the same snap abutments that we would use for a denture, we could put for the partial denture, and the partial denture would sit down in there and snap onto those implants. They're incredibly rigid and stable. You can eat almost anything you want with them and have reasonable success. I think it's a great treatment option. I mean, the last thing, as a periodontist, our whole mission is to save your teeth. So anytime that we can have some kind of restorative option available that we can preserve all the healthy teeth that we can, it's going to be better for you. It's going to be better for the patient. It's going to be better long term for their ability to function, their quality of life, what they are and aren't allowed to eat. People don't think about their diet and what their diet will be like once traditional dentures are placed. They can't have steak anymore. They can't have a lot of the things that maybe they like and that makes their life good to them, because the tougher foods and dentures just don't get along. You lose a lot of function when you go from natural teeth to artificial teeth. And anything that we can do, whether that's adding some implants for a partial, adding implants for an implant supported denture or a fixed denture, all we're doing is trying to add some of that quality of life back to the patient and give them ability to enjoy a lot of the things that they're used to enjoying. Because at the end of the day, that's what matters. Enjoying life, being able to function with your natural teeth, not being in pain every day. That's really what's important.
Can someone with gum disease still get implants?
Absolutely, if it's controlled. So just because you have periodontal disease doesn't mean that you're not a candidate for implants. What I'm looking for is how stable is it? Have we treated it? Have you been compliant with your maintenance? More importantly, are you compliant with home care? How well are you doing at home taking care of it? An implant, I want to be treated as if it were a natural tooth. I want it brushed. I want it flossed. I want it taken care of just as if it was a natural tooth. So my biggest thing that I'm looking for is how well are we doing at the natural teeth that we have? If we're doing a horrible job of brushing them at home, the chances are you're going to lose the implant. If we're doing a really good job and we have charting to prove that you've been pretty stable, you've been compliant, you've been coming in, getting your teeth cleaned every 3 months, you don't have a lot of cavities everywhere, you're doing a good job, then 100%. Yes, you are a candidate for an implant. And I think there's huge value in that for you. But on the flip side, if you come in and there's plaque and bacteria all over the place and your gums are always bleeding, and that 4 and 5 millimeter probing depth, it seems like every time we spot measure when you come in for your cleaning is like a 7 and 8, and then it goes back down. That just tells us that at home you're not doing your job. And so if I place an implant, yes, I can put an implant there. Is it going to be successful? Probably not. And so then it comes to the point, well, I'm going into this knowing that the end result is not going to be good for this patient. I prefer not to do it. I prefer to say, hey, this is why it's going to fail. This is what we can do to mitigate that risk. Let's get on board with that first. Let's get compliant with the cleanings. Let's get everything stabilized. Let's make sure that you can maintain that long term. Brushing and flossing every day is not easy. It's a habit. It's a habit you have to force. It's not something that naturally comes to us. So if that's not there, we have to develop that first. Once we develop that, then I can confidently put an implant in and know that you're going to take care of it and that's going to last you a really long time. Implants are expensive. Anytime you put implant into the name of it, it's going to be expensive. So I want to make sure that you can maximize the value for as long as possible. It's not how many implants can we place in this patient, it's how long can we get these implants to last. Because ultimately, I want to be able to tell you that once we place an implant, it's going to last the rest of your life, but I cannot tell you that. There's research research that shows 96% success rate after 5 years. And then after 5 years, the research kind of falls off. You'll have your hit and miss articles that talk about, well, it's 90% after 10 years or 20 years or 30 years. That's great, but it's very subjective. So you have to take it off a very, very large population base that's diverse. Because if you're taking all your patients that are prophylaxis patients, they don't have disease, and then you compare them to patients who have been treated for periodontal disease and are maintaining it well versus those who have periodontal disease and are not maintaining it, those results vary widely. So it's not how many implants I can place, it's how long I can get them to stay in your mouth. And the ultimate goal is to keep them in there as long as possible. And if I can get everything treated and I can get everything maintained and stable and get home care where it needs to be, then I keep those implants around for a really, really long time. We have patients at our practice that have implants for 40, 45 years. That was when Brandemark was first bringing Nobel implants to the United States, which is phenomenal. Like, we can't even get restorative parts for these implants anymore, but they're fully supported by bone. We have patients that will come to us with implants that were placed a year or two ago, and they're missing all the bone around these implants. So there's a huge divide. And I think the biggest trap that we fall into as providers is just putting everybody into a bucket. Everybody's not a bucket. I mean, this guy could have perfect oral health. Like, he's brushing and flossing, no gum disease, but he could smoke a pack and a half of cigarettes a day. This lady could have periodontal disease, had deep cleanings 10 years ago. She's pretty stable, but every once in a while she'll miss a maintenance appointment. She could have better success with an implant than this otherwise healthy guy, but he smokes a lot. So it's patient specific. So anybody who can tell you how long your implant is going to last is lying to you. It's just not true. I mean, there's way too many variables. All we can do is make sure that we're putting the implant in the very best environment. And the way we do that is just make sure that people are doing what they're supposed to be doing at home. Like, if they're doing their home care, then they have a better chance of long-term success. How long that is, I don't know. I don't.
Hopefully forever.
Hopefully forever, right? Anything that we do, just like with gum grafting or bone grafting, our goal is to have it last forever and not to have to do another one in your life. I can't promise you that. I mean, there's so many environmental, genetic, biological factors that come into play with that. It's impossible for anybody to give you a definitive answer.
For people focusing on whether they should come to a specialist like periodontist or general dentist for implants, is there really a difference between what you focus on versus what general would?
Typically, as specialists, we tend to get the more complicated of cases, whether it's periodontitis, whether that's gum disease in general, implants or bone grafts or whatever the case may be. Typically, if it's outside of the comfort zone of the general dentist, that's typically when we get it. So we have your more advanced cases, maybe some of your aesthetic cases, any of your front 6 teeth on the top or bottom, patients who need an implant in the back, their sinuses or the air sacs that are in their cheeks sit too low, that there's not enough bone for an implant. We do sinus augmentations or sinus lifts, where we add bone to the sinus to make room for implants. Maybe they're trying to place implants or the bone isn't wide enough or isn't tall enough to support an implant. That's where the bone grafting comes in, where we can augment the bone in the jaw to make sure we have enough bone for an implant. So we tend to see the more complex, complicated cases with our training. We have 3 years of advanced specialized training in complex cases for both periodontitis and dental implant placement. We have a lot of that knowledge, a lot of that experience in treating the difficult cases. Where your general dentist, they typically don't get that kind of training in dental school. More the bread and butter dentistry, the fillings, the crowns, the bridges, stuff like that, dentures, partials. That's more the focus when you're in dental school. The dental implant stuff and all the other adjunctive treatments that your dentists do, that's all outside training that they've received outside of dental school, whether that be a continuing education course or some kind of seminar where they learn the basics, right? Every general dentist has the option that if they go into practice and they like dental implants, they can continually get extra education and more experience to the point where they get to a comfort level. I would say the periodontist is the bridge between where that comfort level ends and what the patient needs are. So yes, a lot of general dentists place implants. Yes, a lot of general dentists place implants very well. We have patients come into our office all the time that have implants that were placed by their general dentist, and they look fantastic. They're very restorable. They look great. The bone's healing well. They were well executed. So really, there's 3 primary dental field specialists or dentists that will do implants. Your general dentist, who has advanced training. Your periodontist, who's very worried about gingival contour, aesthetics? Is the bone restorable? Can we do it screw retained? Your oral surgeons who also place dental implants and have advanced training tend to be more traumatic, not that they're causing trauma, but they're treating trauma. So patients was out riding a bicycle and fell and hit the curb and broke 4 teeth out, and they need emergency treatment. Maybe they fractured a jaw, something like that. They're in there fixing that and placing implants and getting function back. Some of the more advanced oral pathology, your squamous cell carcinomas, your oral cancers, where they're doing these big resections, they're very dependent upon oral surgeons to be able to go back in there and get something done for them to get function back. Your periodontists are probably more closely related to your plastic surgeons. We're looking at getting the implant placed in there in the most ideal way possible so that aesthetically, I want you to go back to your general dentist and I want your general dentist to place a crown that even they have a hard time telling which one's the implant and which one's the natural tooth. That's where our focus is as periodontists, where your oral surgeons are more gross function. Like we got to get something in here to get some function back to the patient. And then your general dentist, typically, not always, but typically they're more of the single tooth implant restoration. They took the tooth out. It's not in the aesthetic zone. Don't have to worry about the sinus. There's tons of bone. That's usually where they like to stay. Some advance farther. Some don't do implants at all. A lot don't do implants. It's a liability and a risk that they don't want to manage. So really it all just kind of depends where you're at and kind of what your circumstances are to determine kind of who does what and where you go for the treatment. So
Do you recommend or do you place same day implants or
yes, we do. If it's in the aesthetic zone, we'll place immediate implants if there's enough bone. If not, then we won't. The most ideal implant placement is to take the tooth out and bone graft it and let the bone fully mature. The bone grafts fully mature before going back and placing the implant into that position. It gets riskier when we take a tooth out because the tooth root is typically a bigger diameter than the implant. And so there's some hollow space. It typically gets riskier when you have that hollow space. Yes, we put bone graft. Yes, we cover it. Yes, we do all these things, but it's less predictable. We don't always know where that bone's going to go. We don't always know if that bone's going to fully heal the way we want it to heal. And there's a height variation. So when we're talking about aesthetics, we don't want to see titanium under our gums. We want what we call our gingival contour, where our gums are on the teeth, to look natural, to look the same as all the natural teeth next to it. It's much, much harder to do that with an immediate placement because you have a big hole and you have to try to get that implant at an appropriate depth. And we have guidelines that we go by. That it's just a guideline. If we can fully heal that bone, now we know exactly where our gum tissue is. We know exactly where our bone level is. And we can very precisely put that implant into a position that restorably is going to give us the best outcome. Now, if you lose one of your front teeth, it's probably reasonable that you're going to want a tooth back there as long as possible. And doing an immediate placement is certainly a great option because we can cut the treatment time in half by doing it immediately. It is a little bit less predictable than doing it the ideal or the gold standard method.
you could also do like a flipper in the meantime?
We can. So there's several temporaries. At our office at Westport, we never let a patient walk out missing a tooth. We always make sure whether it's an extraction for an implant or it's an extraction without an implant, we want to make sure that they're not walking around missing a tooth. So there's a couple options. The first one is called an Essex retainer, and it's a clear Invisalign tray, like an ortho tray. And wherever the tooth is that we're taking out, we put composite in there to kind of match the adjacent teeth. It's not the prettiest thing in the world, but it is very hard for the outside person to tell that you're missing that tooth. The second option is a flipper. The flipper is more aesthetic. It kind of clips in. Both of those options have to be taken out when you eat. You have to take them out at night. So they're not really functional. It's more for just aesthetics, just for looks. Immediately post-surgery, the Essex is almost always better. And that's because I have almost unlimited adjustability to it to make sure that the temporary is not touching the implant. We don't want, just like we talked about immediate loading, we don't want forces on the implant during healing. The flipper, it's more contour. That's what makes it more aesthetically pleasing, but it's a lot harder for me to adjust it. I don't have as much material to remove to make sure it stays off of the implant. So typically what we'll do is like a two-stage thing where maybe we'll make them an Essex in the beginning and then later on transition them to a flipper, which is nicer looking once that implant has to heal and do all that. Because it's kind of a two-stage process, especially if we're bone grafting first. So in an immediate, it's a little different, right? Because you're placing the implant immediately, your healing time's cut in half. You just got to deal with something for 3-4 months and then you're done. When we do it the traditional way, where we take the tooth out and we bone graft and let that heal, you're in that temporary for 6 months to up to a year. So we want to make sure that you have something that is going to function well for you aesthetically for that duration of time. And typically flippers do a better job at that than the Essex retainers do. So we'll start off with an Essex retainer in the beginning. That'll get us through the initial healing. That way we don't have pressure on the surgical site. And then the general dentist, once the gums have had time, 2, 3, 4 weeks to kind of heal together, then the general dentist will fabricate something more substantial and something that looks a lot nicer to go the duration of time.
Who restores the implant?
So the restoration or the crown for the implant is done by the general dentist. So as a surgeon, we're putting the screw in the bone and we're making sure that that screw heals and the bone heals appropriately. We shape the tissue, we do all this, but we don't make it look like a tooth. That's kind of outside of our realm. So once the implant is stable, it's healed, we test it, we make sure that it's solid. It's done something called osseointegration. So the bone is healed around the threads of the implant, kind of locked it into place. Once that happens, that implant's a part of you. It doesn't move, it doesn't shift, it doesn't come in and out, it does nothing. It's there. Once we get to that point, then we put a different top on it that kind of sticks out of the gums a little bit, and that heals for 2, 3 weeks, and then your general dentist will be able to access the implant. And at that point in time, pretty much all care gets turned back over to the general dentist, and they make that implant look beautiful again. So yeah, we typically, we're the bottom, the general dentist does the top for the most part.
What tools or technologies do you most often use in your work?
The main one is the CBCT or cone beam tomography radiograph. It gives us a three-dimensional analysis of what we have going on, of all the hard tissues. Whenever we're planning for a dental implant or a bone graft or even a soft tissue graft, crown lengthening, pretty much all of our procedures, the CT will be able to allow us to look at it in 3 dimensions, make sure we have good bone quality, make sure we have enough bone to support an implant. We can digitally place the implant that we want into that area and see what it's going to look like. What is it going to look like with an implant in here? Am I going to be able to put it in a good position where the general dentist isn't going to be mad at me because they can't put a crown on it? Is it in the right position to where when like the occlusion we were talking about earlier, when the top and the bottom come together, is that implant going to get traumatized? Do I have enough wiggle room in the bone to be able to position it in an area that's going to be most ideal? For crown lengthening, it's going to tell us whether or not we have enough bone structure around the tooth that we're not going to cause more damage by doing the crown lengthening than we are just leaving it the way it is. Bone pathologies, tooth pathologies, failed root canals. It's so universal. It has come so far in the last 10, 15 years. It's unbelievable the things that we can do with this image. That's something that we use on a daily basis. And then, of course, we have our periodontal specific technologies being the laser. We use a YAG laser that's been around for a long time, early 2000s, and it really hasn't changed. It came out and was so beneficial the way it was originally that they do software updates and all this. But 20 years later, here we are, and the same laser is still just as effective as it's always been. It's just technology is incredible. Patient education, combining all the new social media type stuff with the digital radiographs, being able to put them all together. We do a lot of intraoral scanning that's digital. So we can take that intraoral scan image and we can marry it to the CBCT. And so when we're showing patients kind of what our thought process is, we can see, okay, well, they currently have a tooth. It's infected. We know it has to come out. We know we want an implant. But can we put the implant in a position, if I had to do it right now, to give them the same exact shape and style of crown that they have now naturally, when it comes time to restore that implant? We can do it all digitally. We can do it right there in front of the patient. We can talk them through situations. Just photography with the intraoral scanning, the CBCT, and being able to overlay all those things on top of each other is so powerful. I mean, patient education is better now than I think it's probably ever been in the history of dentistry, just from the technologies that we have to be able to visually show the patients what we're talking about. I can't imagine what being a periodontist 30, 40 years ago was like. I mean, people had to have so much trust in you because they really didn't understand what you were doing or why you were doing it. They just put their faith in you. And now we can show them like, hey, this is the reason we're doing what we're doing.
Mhm.
This is why it's important. This is what will happen if we don't treat it. This is how it can progress. When we take the measurements and they're deep, this is why. This is what we're looking at. Our CBCT, if they have a lot of plaque underneath the gums, it will pick it up. And we can show them 3-dimensionally, like, look at this. The roots of your teeth are anatomically made to be smooth. Yours, we have mountains everywhere, and this is the bacteria, and we can show them where it is. We can show our hygienist where it is. Research shows that you got 6 millimeter or more probing depths. Even if a hygienist top of her game, like been doing it 20 years, is just amazing, she's going to miss over 60% of all the bacteria that's in that pocket because it's hard. Some of it you can't even feel. I've done osseous surgeries following deep cleanings that I've done, and I've found bacterial plaque behind. And you run your explorers and your tools, it's all by feel. And sometimes it's so flat and hard you can't even feel it. The CT is incredible. It's a huge advantage. Mixing all this stuff together, just patient education and patient understanding. Because if the patient can understand why you're doing what you're doing, they're going to be more involved in the process. And that's the most important part. It's not about getting the surgery. It's not about getting the implant. It's about the patient being involved. Like, what are you going to do once this happens? It's like, this is all in your court now. Like, I've done my 10%. Now the 90% is on yours. You understand where we came from and where we're at now. And their compliance is more likely to happen because they understand what's happening in their mouth. And I don't think there's nothing in dentistry right now that can compare to that. You can have all the fancy AI and all this stuff. Nothing compares to being able to educate your patient and show them, minus being able to put it in their hands. They're going to be able to know exactly what's going on, why it's going on, and what our treatment is hoping to accomplish the process.
What do you do to help patients who are anxious about treatment?
Yes, we have several options. In our office, we offer oral sedation. So it's a medication you take the night before and an hour before your appointment. They're anxiolytics, so they reduce anxiety. And we also offer in-office IV sedation. We do sedation for our patients who are healthy enough to undergo it in an outpatient clinic. We offer nitrous oxide, lapping gas. We use that probably more often than anything else. With the first two, the oral sedation, IV sedation, the patients can't eat after midnight, and they got to have somebody there to drive them, and they have to have someone to take them home, and they have to have someone to stay with them for the first day. With the nitrous oxide, you don't. So you can come in by yourself, and once we turn the gas on, you're completely awake the whole time. You just care less, is what I like to say. It's very safe. It's our primary sedation for children, even in the general dentistry world. And so it's probably our workhorse day to day, just to get people over the edge. The funny thing about periodontal surgery is that it's really not painful. The worst part, just as it is in the general dentistry world, is getting numb. Once you get past the injections, almost everything we do is easy. Tissue grafts, bone grafts, implants, super easy. You don't feel anything. Extractions are probably the only thing that is different. That's the most traumatic thing that we do as periodontists, and you do probably as a general dentist, is extractions. And that's because we can't take pressure away. The only thing I have to take pressure away is IV sedation. Most of the extractions I do, not super necessary. Most of these are periodontally involved teeth as opposed to oral surgeons where they're focused on taking out really tough teeth. I refer some extractions to oral surgery because that's not my wheelhouse. That's not where we live most of the time. Most of our IV sedations are more the difficult or longer cases where maybe we're doing the full arch extractions and we're putting implants in the same day. And these are very long, 4 to 6 hour appointments. And it's just a lot for the patient. That's usually where our IV sedation comes into play. And then our oral sedation, that's more of not a huge procedure, but a super anxious patient, one where the nitrous just isn't going to be enough by itself. That's where the oral really comes in handy. Just as long as they have a driver and all that, it works really well. Gets a lot of patients who otherwise wouldn't be able to receive treatment, the treatment they need.
How can patients prepare for their first visit to a periodontist?
Really?
Medication list,
Yeah, medication list.
either x-rays from their dentist or anything?
Yeah, if possible. A lot of times we'll reach out to the general dentist and try to get those beforehand. If not, we'll just take them when we get there. We're not your primary care provider as far as dentistry goes. Typically don't charge for radiographs. If there's radiographs that we need at the time of your appointment, we're going to take them. We're not going to charge you for them. That's your general dentist's job to maintain all that. A lot of times it's just trying to get a hold of the dentist. They're busy, you're busy, everybody's kind of cat and mouse phone tag type thing. Just makes more sense for us to take them ourselves. At our office, we send you out a text the day that you schedule. You can do all your health history, medication history, all that stuff, dental history online, and it submits it into your chart, and it's ready to go. The only thing you got to do is show up. Show up with questions. We love questions. We have new patient exams that are longer than probably any other specialty of dentistry, and we do that for a reason. We want people to be able to understand. Education education, you can't put a price tag on that, regardless of what we do. If the patient doesn't understand, I feel like I haven't done my job effective, right? So it's not the surgeries, it's not the deep cleanings, it's not the huge wins when you see a patient with 10 and 11 millimeter pockets going down to threes and fours. Those are great. But if the patient still doesn't understand what's going on, then I haven't properly done my job. So come with questions. We're always ready to answer questions. We usually always start with an exam. So we'll come in, we'll say hi, we'll introduce ourselves and kind of get an idea of what you're there for. Most of the time we'll get a referral sent over to us from the general dentist. A lot of times we don't. So sometimes we walk into the room and we have no idea why you're there. We always like to try to figure out what the patient's there for, and then sometimes they don't know what they're there for. Sometimes they said, I went to my hygienist and she said I needed to come see you. Or they'll come in and they'll say, I have all this recession, but then the referral from the general dentist wants us to look at an implant in the top left. Sometimes what the patient understands why they're there is not the same as what the general dentist may have sent them there for. So pretty much the first 10 or 15 minutes of the appointment is just making sure all of us get on the same page. That way we're all discussing the same thing. We all have the same interests at heart. And then after that, we'll do an exam. Your general dentist or your hygienist had already taken measurements of all your teeth. We're going to do it again just because you want us to. And what I mean by that is, what if the hygienist wasn't pushing hard enough? Or what if she was pushing too hard? Maybe my numbers are way different than what her numbers were. That's going to have a huge, huge play in the trajectory of treatment. So you want to make sure that, hey, let's get a second set of eyes. Let's do new charting. I know it's not fun. Nobody loves it, but it's so incredibly important because it could take you from immediate surgery to, hey, let's do a deep cleaning and see where we come from. I mean, those are two very different treatment plans with two very different expenses associated with them. We always start with that exam. We're looking at all the soft tissues in the mouth, making sure we don't see anything that's abnormal. We're checking outside, inside. We're doing everything. We're pushing on your teeth, making sure they're not loose. We're checking the furcations where your roots split apart from each other, making sure there's bone there. We do some restorative checks, but pretty much only for the obvious stuff, like if a crown's missing or a restoration's not there, or if there's just huge cavities everywhere. And that gives us something to talk to the general dentist about, because really it's a relationship, not only between us and the patient, but between us and the other provider, right? So really the first new patient exam is all about getting all the documentation we need, figuring out what the patient's there for, and then making sure all of us get on the same page. That way, if they were sent over for an implant and then I find that they have advanced periodontal disease, well, the letter I send back to the general dentist is going to say, we're going to treat her for advanced periodontal disease. We're not touching an implant right now. That first appointment is just for us to touch base, make sure we're all on the same page, make sure we're all seeing the same thing. And then we can come up with a treatment plan that's going to be best for the patient and hopefully be able to give them some different options to choose from, not just one, which is always ideal. That way the patient has some autonomy in how this whole thing plays out.
For hygiene products or regimens, what do you recommend?
I do recommend the Oral-B IO electric toothbrush. Multiple reasons. One, it tells you if you're brushing too hard, but really it's the geometry and the physics of the head. The smaller round head accesses the areas between the teeth much better than your standard shaped toothbrush. Sonicare is a great toothbrush. It has pressure sensitivity as well, but they maintain that large rectangular head, which just doesn't get into the spaces as well as an Oral-B does, in my opinion. From my clinical experience, I see better results with it. As far as toothpaste, Crest, Colgate, pretty much any of your over-the-counter toothpaste are going to be fine. If you have problems with a lot of bleeding, your numbers are right, but you just can't keep gingivitis under control. One, we need to talk about your home care. Or two, we'll give you something called Periodontics, which helps more with the bleeding in some patients. Find it beneficial. If you have a lot of sensitivity, we love Sensodyne. It's a great toothpaste to help with sensitive teeth. It does not work overnight. It takes time, but it does eventually work and then maintains it for a long period of time. And then, of course, more on your side, if they're more prone to cavities, something like Clean Pro 5000 or something like that. High fluoride toothpaste, it can do wonders for people who have dry mouth or just more prone to dental cavities. Other than that, I mean, we don't have any magic wand. I wish we did. It's just your standard over-the-counter stuff. I think the most important part is just doing it and making a habit of it, which is very, very complicated to do.
Do you have any preference on like different floss, waxed, unwaxed, or does that matter?
I don't. I think my biggest preference is whatever you have that you're going to use. I leave that up to the patient. I'm not a fan one way or the other. I think if you have really, really tight contacts, like the Glide wax, the ribbon floss, probably is easier for you to get in between your teeth than if you have wide open contacts where you can pretty much use anything you wanted to get back there. They have all kinds of different instruments and stuff that you can hold floss with for people who don't have the manual dexterity. There's all kinds of stuff on the market. Really, the only suggestion that I would have is that don't get tied up into the hype, right? So it seems like every 6 months I see something on social media. Last year it was charcoal toothpaste. Horrible idea. Don't ever do that for multitudes of reasons. One, it's pumice. All toothpaste has pumice in it. Of your normal Colgate and Crest toothpaste, it's very, very fine. Charcoal's a lot denser. It takes away a lot of enamel. That's how it whitens your teeth. It doesn't erase stains. It literally takes the enamel off that has the stain on it. And over time, your teeth are actually going to get yellower because your enamel is the only part of your tooth that's white. Once you get to the root, which is underneath the enamel, it's going to turn yellow, and then you're out of options at that point in time. So stay off of the social media hype. Super high peroxide with baking soda, pumice that you can make at home. It burns tissue. If you don't dilute that peroxide enough, it will actually burn your gum tissue. So just be careful. Be smart. The Crests and the Colgates, they've been around for a long time, and they work really well. If it's not broke, don't fix it type of thing.
You recommend any mouthwashes?
I like Closest a lot. It's kind of our alternative to chlorhexidine. Chlorhexidine is fantastic, but as you know, there's a lot of complications that come with it, staining your teeth, and you'll have some temporary change in your taste. Closest it does a really, really good job, but it doesn't have all those side effects. It doesn't have the staining. It doesn't have the taste change. It doesn't have all that. TheraBreath is a good one. Smart Mouth, for instance, is good. It's pretty expensive, but it does a good job, especially if you suffer from bad breath. We have patients who get by very well with warm salt water rinses because they can do that as much as they want, and the gum tissue loves it. It doesn't do much for bad breath, but as far as gum and gingival health, it does a lot. So really, that it all comes down to patient preference.
You recommend any like tongue scrapers or anything?
I do recommend the tongue scraper. I don't care what kind you use. But a lot of the patients, I probably see it more in the adolescents than anybody, but the ones who constantly have bad breath, even though their teeth are clean, there's no plaque anywhere, but they're bad breath all the time. It's usually a tongue situation. Tongue scraping will be beneficial for that night and day as far as being able to keep that bad breath at bay. As long as they're brushing and flossing and doing all the stuff they're supposed to be doing, tongue scrapers is certainly beneficial. And it keeps bacterial colonies under control a little bit better.
What is your favorite part of your job?
People. It's just incredible. Just dentistry as a whole. We have one of those professions where, one of the greatest things that separate us from the medical side is that a patient can come to us with immediate problems, with pain, with swelling, with huge intraoral infections, and we can treat that same day. We may not be able to make it feel better same day, but we can treat it same day. We can take patients who have gummy smiles, for example. When they smile, you just see gum, you can't hardly see teeth. And the same day, they can walk out seeing all of their teeth. It's life changing, not in the sense of life or death, but it can really change someone's self esteem and how they look at themselves and the confidence they have in themselves just from something that takes 90 minutes for us to accomplish. Same thing with any kind of gingival grafting and stuff like that. Implants, especially in the aesthetic zone, which is usually your canine to your canine, top and bottom. Getting a tooth back there that looks natural, it's amazing. General dentistry, you see it all the time. You see tons of cavities everywhere, and you fix it all up, and the patient's got a brand new smile, or veneers, or all. Just our field as a whole is very rewarding, even though people don't like to come and see us. We're not everybody's biggest fan. It is very rewarding to be able to do that for people on a daily basis and to meet people from every walk of life, from CEOs of major corporations to kids that are still in elementary school. I mean, the retired folks who are living the dream now. It's just fascinating, and being able to learn things from all these different patients on a daily basis is, I don't know of any other career where I could provide what I can here and be able to have those interactions every day. It's fantastic. Yeah.
So for anyone that's interested in making an appointment with you, do they need a referral? And if not, or if they do, where can they find you?
Yeah, so you can find us at Westport Periodontics or westportperio.com. You don't have to have a referral. We have patients that do walk-in appointments. We will ask you for a referral at your appointment because we always want to be in communication with your general dentist. I think I mentioned earlier, so your general dentist is the quarterback. We're just the wide receiver. So we want to make sure that you have somebody that's looking out for everything. And so if you don't have a general dentist, that's fine. You can still come see us and we'll still give you our best judgment on kind of what your current situation is and what we can do to help you. And we may be able to point you in the right direction as far as general dentists that we think would fit your personality well, and we'll go from there. But yeah, I mean, anybody who's interested is welcome to come hang out. We're pretty cool guys. I mean, most of us are nerds, but we're not. We're pretty cool. So
Well, thank you so much for sharing your time and expertise today. I know our listeners will walk away with a much better understanding of gum health, implants, and gum grafting. If you found this conversation helpful, please give it a like, leave a comment with your biggest takeaway or any questions you have for Dr. Barrett. And don't forget to subscribe so that you never miss an episode of Dental Dental. Until next time, keep smiling. Thank you.